So we have to deal with calcium in different parts of our body, and this is really a difficult issue, and we are limited with what we have in our hands so far to treat calcium in an efficient way. So what are the challenges associated with problematic calcium in the different areas in our body? In the vessel areas, it's dissections, perforations, embolization, and also access for large bore devices. And this is very important for structural heart, stent crush, wherever we place our stent, and in the peripheral field also vessel recoil. So this is just showing how Shockwave is working. There is no tone. Can you?
Emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. When the waves impact the calcium at nearly 50 atmospheres, the vessel becomes more compliant.
So I think this is really the outstanding tool or technology of lithotripsy that is really making a distinction between soft and hard tissue, and that it has a localized field effect within the intimal and medial calcium, and it's really cracking this in a sufficient way and therefore modifying the vessel. So you see here in a very nice way, and I guess Andrew already has shown you that, you see here CT images from calcified vessel areas pre-IVL and post-IVL treatment, and you see with the areas the cracks in the calcium. And what was really amazing for me when I used this technology first, seeing that the vessel compliance is really increasing and that there is no distal embolization, which I could not imagine before when you deal with these calcified lesions. So Andrew already has presented the data about the new technology. This is the Shockwave M5 Plus catheter. Gives us broad access options with increased catheter working length of 135 centimeters. And it's larger because we can also treat vessels up to 8 millimeter, and it's faster. It increases the procedural efficacy with 50% quicker cycle time. So this is the overview about the new M5 and the S4 for mainly below the knee treatment. We have data out there in the peripheral field that this technology is really showing a great, exceptional safety profile. You see here in the bed 3 RCT and then also in the observational study, really nearly no dissections, no perforations and no distal embolizations. And the acute outcome effect is really amazing. When you look at the pre-procedure stenosis and the post-IVL stenosis and then the final stenosis. So this is really an efficient and safe tool to treat vessels. So calcium is still the Achilles heel of IVD, but IVL is sufficient to overcome the challenges. And with that, I want to say thank you and hand over to the next speaker, which is Michel Bossier from Münster in Germany. And he is talking about safely changing vessel compliance and achieving luminegate for IVR and DVR delivery. Please, Michel.
Thank you, Marianne. Thank you for the kind invitation as well. So we all know that hostile calcified access is an exclusion criteria for EVAR-TVAR procedures, and those complications are always associated with both perioperative and, of course, long-term morbidity and mortality. As you can see in this case here, this was a lady with narrow access vessels. She would need treatment for a thoracoabdominal aortic aneurysm, and I wanted to advance my TVAR endograft in a staged fashion, and this rupture occurred. So what did I do? I put in some covered stents, and I still wasn't able to push through my thoracic endograft, so I did an ilacrofemoral bypass, and then I was able to treat this patient. So solutions so far for hostile calcified access have been open conduits or paving and cracking or endoconduits, as we see endoconduits with paving and cracking technology. But of course, invariably, we can, with this technique, we close up our patent hypogastric artery if we close up the entire iliac artery. So we all know the PARC classification, but let me introduce you a new type of hostile access criteria. We have the mild one, we have the moderate, as we all can appreciate. And then we come to the severe and the concentric ones, and these are the hostile, which provide the hostile access, especially if the MLD is less than 7 millimeters. So, of course, we have low-profile solutions, but at what cost? Not all technology is as successful as the other one. So, one solution could, of course, be the Ivl treatment. This has already been mentioned by Marianne. We're very happy because we need the 8 millimeter device for hostile access. And what we also saw across all vessel beds is the same outcome, especially for us now important in the iliac segment. Even a cohort analysis from Disrupt Part 3 analyzed their iliac patients when they treated 118 patients. Of those, there were 17 patients that were treated for large bore access, and only extra stenting was done in 41%. So what does Ivl do? You want to change your vessel compliance, and you want to facilitate, you want to facilitate endograft delivery. So when should we use Ivl? When we have an EVAR, when we have a patient requiring EVAR, if it's an eccentric stenosis less than 5 millimeters or concentric less than 6, in FEVAR, BVAR, or TVAR cases, when it's eccentric less than 6, or if it's concentric less than 7 millimeters. So it's very important before starting your procedure that you accurately check all lesions. So don't compromise on graft selection. When I have a patient, he has narrow vessels, I order a low profile endograft. When I have normal vessels, I use a standard device. Calcium doesn't bother me anymore with this new technology. So I have two examples for you. This was a 71-year male patient with a large aneurysm at the arch, and the plan was to implant a thoracic endograft with an in situ fenestration for the left subclavian artery, a 20 French device. And these are his access vessels. On the right side, he had a 6 millimeter self-expandable stent, so we could forget about this. And on the left side, we have this heavily calcified external iliac artery with an MLD of 5 millimeters. So this is an image over a 14 French sheet, and then after that, the 8 millimeter was not yet available, unfortunately, but I used a 7 millimeter Ivl catheter. First go up to 4 atmospheres, so very low pressure to really crack your calcium to change vessel compliance, and then go up to 6 atmospheres, and then I was able to advance, first of all, a sheet and then the endograft itself, and I was able to finish the procedure without any problems. Here's a short video where you can see the Ivl working, first dilating to 4 atmospheres, and then going up to 6 atmospheres, and then, of course, after that, there was no problem to advance first a dilator. Before I unpack the more expensive device, I first check with the dilator that I can pass through, and then you can see how smoothly the endograft could go over. After endograft delivery, there was a small plaque shift which closed the hypogastric artery, and I think the hypogastric artery is very important, so we reopened it without any problems, and the hypogastric artery is patent again at finalization, as you can see here again. So these are very exciting images, I think personally. You see pre and post Ivl treatment. You see the luminal gain going from 5 to 7.7 millimeters. The last example is a 77-year-old female patient with a type 3 thoracoabdominal aortic aneurysm. Plan, of course, was to do a low-profile BVAR, access with the right femoral and left axillary artery. As you can see in my drawing, she has always those stenosed hypogastric artery, stenosed iliac arteries on both sides. As you can see again here on the CT scan, the right side was the more accessible one. The left side had a very tight, narrow, calcified common iliac artery stenosis. So I went from the right side, as you can see in these pictures in this video here, where you can appreciate the heavily calcified axis. This is the 8 millimeter device, which was then available. We were very grateful for. And we treated the entire iliac axis, which was necessary. And after that, you can see how smoothly we were able to advance our endograft. This is the image after Ivl treatment. And this is amazing how we, without any problems, without any pull-through wires, can advance our endograft. This is tight stenosis on the left, also heavily calcified, so I opted to go here from above, from an auxiliary approach. You can see the catheter struggling, going through it. So after Ivl treatment, I was able to advance my sheet without any problems, and I attached it with a balloon expandable covered stent. I treated the entire iliac axis as well. She required stenting in the external iliac because she was also a PAD patient, and afterwards the ABI index increased on both sides. And these again, pre and post images of both sides where you can see the luminal gain and a perfect outcome. So in conclusion, it's predictable safe. You have a low risk of rupture or dissection by changing the vessel compliance. So I don't need any more endoconduits or open procedures. It's distinctively intuitive, so we don't need that much use of stents anymore. And it's consistently effective by optimizing luminal gain with low residual stenosis. Thank you for your attention.
Thank you, Michel. Great cases for this indication, which we need to do more and more. So the next speaker is Enrique Alejandre Lafont from St. Gallen, and he is giving us a talk about the paradigm shift in treating fem-pop Clti. Please, Enrique.
Thank you very much. So we already saw some data and this great talks of Andrew Holden in the last session and Professor Brodmann and Dr. Bosius. So I would rather like to focus on cases to convince you that AVL is a paradigm shift in treating femoropopliteal calcification. So we all saw this data. We know that calcium matters, so we can skip on that. And if we look at the vessel preparation methods we got, then PTA is no more than pressing the calcium inside healthy tissue, so the calcium mostly stays the same. And atherectomy and calcium is difficult. If you do an unidirectional atherectomy like Hawk, then usually you skip from the calcium to the healthy tissue, unless you use Panteris, for example, where you can see where you cut. But if you use the Hawk, which I use a lot in non-calcified lesions, then you skip from the calcium and you cut inside healthy vessel, and this is not the solution. Scoring PTA and, for example, non-slipping element PTA works with lower pressure, but the principle is the same. One advantage is that you cause longitudinal dissection and not this diffuse dissections, and so it's not that flow relevant. In IVL, we apply highly focused ultrasound, and PTA or dilatation of the vessel is not the principle. So if you look at this case, you can see a heavy calcified common femoral artery in this woman who refused surgery. And this is the result after PTA. So you can see there's still flow-limiting calcium in the origin of the SFA. But if you treat this lesion with IVL, you can see here at 4 atmospheres. I didn't rise the pressure. It's stayed at 4 atmospheres, and you can see that the balloon of the IVL device opens up. And when you see in the cadaveric SFA, in this case, you cause cracks inside the calcium, leaving the rest of the vessel, in this case here, healthy and undamaged. So if you do IVL in this case, you get this result. And you can see the calcium, but it's not flow relevant anymore. So these are the cases that we see all the time with IVL. Let me show you another case. This is a patient with claudication. You don't want to stent this segment. This is a heavy calcified lesion. If you see the angio, you wouldn't think that you can get out of this intervention without a stent. The problem with a stent in this case is that you have a mismatch from the distal landing zone to the upper landing zone, where you would use a stent that's oversized and will create with chronic outward force intimal hyperplasia in the P3 segment. Or you have to use 2 stents. But if you use IVL, you get this result. This is not a perfect result, but it's not more flow relevant. You don't have recoil, and this patient got out without a stent. So there are 4 things you have to keep in mind when using IVL. It's not a dilatation of the vessel. The first thing is you have to oversize the device by 10% to make contact with the vessel wall. The second is you have to avoid a therapeutical mismatch. So you have to overlap the devices The next thing is you have to deflate the balloon as much as you can, and then it's not the pressure inside the balloon what's relevant, but the contact with the vessel wall, because the energy delivery is not improved by overinflation. These are 2 more cases showing the results after IVL without stenting in these 2 patients. So you can see it works, and this is what convinced me. And we have these data. Next month, the final results of the PID3 trial will be published. But so far, we can say that we have a lower complication rate, lower stent rate, lower rate of relevant residual stenosis. And so, in summary, IVL is a safe, easy, fast, and predictable method. If you have a resident that can do PTA, he can do IVL. But it's not said that he can do atherectomy. So this is very fast and easy procedure, and low complication rate, a steep learning curve. You leave really nothing behind, and we have so far very convincing data. Thank you very much.
Thank you, Enrique, and you made a really good point at the end. It's a very easy to learn procedure, which a very short learning curve. So thank you very much. Next talk is from Nayan Dulasadian from London, mitigating risk and improving outcomes in calcified CLDI patients. Please.
Thank you very much, Dr. Brodmann, and thank you for inviting me to speak today. My name is Narayan. I'm an interventional radiologist at St Thomas's. My disclosures, and I should also add to this another disclosure: I've spent far too many hours of my life picking out embolus from tibial arteries and trying to get aortic endografts of calcified iliac vessels. So what are the hurdles for endovascular therapy in calcified CLTI? They're the intraprocedural hurdles of flow-limiting dissection, distal embolization, acute recoil, and a very high risk of bailout stenting. Often in CLTI patients you have a suboptimal runoff, and I don't like to be forced to stent when I don't want to do that as a primary procedure plan. Post-procedure, we're at risk of subacute recoil, poor uptake of anti-restenotic drugs, and managing in-stent restenosis when we do have to stent in a difficult situation. So let me show you some cases here. It's very rare you get the opportunity to control your own work in the same leg and the same lesion, but this is a 59-year-old patient who presented to us first in February 2019 with rest pain in his left foot and a few small ulcers. He's a type 1 diabetic, and he's had a renal transplant before. You can see the amount of calcium here on the angiogram, and you can see this kind of focal, tight calcified stenosis. What did we do in 2019? Well, we crossed the lesions, and we used a rotational atherectomy and did a plain balloon angioplasty, a drug-coated balloon angioplasty, and what are we left with here? We're left with a filter that's full of embolic material. We're left with trash in the perineal arteries. So you know how this story goes. Lots of difficult tibial work, some thromboaspiration, some angioplasty, and finally we managed to get this patient off the table with a decent runoff. The same patient presents to us 2 years later with new occurrence of rest pain in the same foot. He's got a fourth toe ulcer with pus expressed from the wound, and you can see here the disease has essentially recurred in exactly the same place with exactly the same severity, but now we have IVL available. You can see on the intravascular ultrasound pictures how calcified this disease is, and you can understand how this is going to respond to plain balloon angioplasty, and we know how the atherectomy story ends from the previous procedure. So we used the intravascular ultrasound to size accurately for the procedure. As has been mentioned before, it's important to oversize the balloon correctly to get good wall apposition. You can see the Shockwave balloon expanding without any additional inflation, which means that the Shockwave pulses are breaking the calcium and changing the compliance of the vessel wall. We see a plain balloon angioplasty and a drug-coated balloon angioplasty, and we end up with this IVUS image, which shows a greatly improved luminal gain, an excellent flow on the angiogram, and no trash at all in the tibial vessels. I'm feeling very confident. We've got time on our hands. The patient's feeling good, so we move on and treat the tibial lesions as well with the tibial IVL catheter. Again, we end up with this very pleasing result. The clinical story of the patient: his rest pain has gone, the ulcer's dried out, but he has osteomyelitis, so we have to take away the fourth toe, and his fourth toe amputation wound is now healing well. Is the acute result better? The Disrupt PAD results from 30 days suggest yes. Is it more durable? Well, we're going to find out next month what the one-year results from Disrupt PAD 3 trial are. I can tell you one thing: it's definitely less stressful for the patient and for the operator. And what you can see here from this Disrupt PAD3 data is that the results are, it's very predictable between the RCT and the observational study where all comers have been treated, that the safety profile of this device is excellent. It does not trash, it does not dissect. Here's another patient. This is an 80-year-old male with a history of coronary artery disease, previous TAVI, heart failure. He's got a very rapidly progressive ulcer following a small blister to his foot. You can see this long SFA lesion with heavily calcified stenosis, and again, a very poor runoff. In this case, I'm going to be worried if I do atherectomy that I'm going to trash the single vessel runoff and leave him in a worse situation than I find him. So we use IVL here. We get a really good result. Because of the clinical status of the patient, I make a primary decision to place a stent, and you can see the superior stent looks great. I always used to say to my trainees, if the superior looks this good, it means that you've undersized the stent. But actually with IVL, we can get this kind of result with a proper sizing, and it's a really, really safe and effective vessel preparation for the superior stent. And you can see these final angiograms, there's no trash at all, excellent flow to the foot, and the ulcer is now almost healed. I'll leave you with one final case. This is a 64-year-old male, diabetic with a necrotic hallux. You can see this focal occlusion in the popliteal artery, as we were talking about before. This is what we call a no-stent zone. I particularly don't want to stent the popliteal artery in a 64-year-old guy who's essentially otherwise healthy, active. I know if I put a stent there, it's going to occlude quickly. You can see the IVUS image, a tightly calcified stenosis. I have to do a little bit of pre-dilatation to get the shockwave balloon through, but you can see this very, very pleasing result with the intravascular ultrasound and excellent flow on the final angiogram, again, without having to stent, without having to cause a problem to the runoff. So I'll just leave you with this data, which was presented at Viva last year. IVL shows very, very consistent outcomes across multiple vessel beds, lesion types, and specifically in critical limb ischemia patients who are the most at risk and the most difficult to treat. This is making life a lot less stressful for all of us. Thank you very much.
Yes, thank you, especially for showing us how safe it can work in CLDI patients with below-the-knee disease. So we are running out of time, but just one comment from each of you. What are you thinking is the biggest impact this technology has in our daily life? If you want to start, Michelle.
I think Ryan concluded it perfectly. It's way less stressful for us. I mean, even if I have heavily calcified access, I have no problem anymore.
Yeah.
For me, one of the most important things is that you can do IVL without jeopardizing any other method. So you can try IVL in calcified lesions. If it doesn't work, you can do all the other tools. You can use all the other tools that you have. And the other thing that I mentioned is that it has a really steep learning curve, and it's easy to use, and so it makes a perfect tool for our cath lab. And this is perfect.
And New Year for CLDI patients, I think where we really have to preserve our limbs.
I think this has been a whole paradigm shift really for us, right? You know, before you could put a patient on the table, you have some tibial trash, your whole day is ruined, right? You're there for hours trying to fix the damage. The safety profile and really the way you can rely on a consistent outcome with IVL, it's really changed my life.
Yeah. Mine too. Thank you very much. I guess it was a really good symposium about this very important technique to modify calcium in different beds in our body. We need in the meantime, not only in the infrainguinal vessels, but also in the iliac vessels, in other vessel areas, in the carotids, in renal and mesenteric arteries, and also a lot for exercise treatment. So with that, I just want to conclude and wish you all another good morning at this first meeting here in Europe on site after this pandemic. And thank you, Shockwave, for this symposium. Thank you very much.